Hello everyone. Today we are going to explore an important and often high risk area in musculoskeletal physiotherapy, tumors and pathological fractures. So, unlike mechanical conditions, these presentations may indicate serious underlying pathology, including primary bone tumors or metastatic disease. For physiotherapists, this topic is critical because it involves red flag recognition, clinical safety, appropriate referral pathways. So, early identification can significantly impact patient outcomes and survival. So, what are tumors in the musculoskeletal system? Tumors are abnormal growths of tissue which may be benign tumors, characteristics slow growing, well defined, non metastatic. Example osteochondroma, lipoma. So, second one is malignant tumors, characteristics aggressive growth, potential to metastasis, destructive to surrounding tissues. Example osteosarcoma, Ewing sarcoma, metastatic bone disease. Key clinical insight. In adults, most bone tumors are metastatic rather than primary. Common primary sources include breast, prostate, lung. And then pathological fractures. What is the definition of pathological fractures? A pathological fracture is a fracture that occurs in weakened bone due to underlying disease rather than normal trauma. So, what are the causes? The bone tumors, osteoporosis, infection, metabolic bone disease. What is the mechanism? The bone strength is compromised due to structural destruction, reduced mineral density, altered load bearing capacity. Even minimal force or normal activity can cause fracture. Pathophysiology, tumor effect on bone, tumors disrupt bone thought, osteolytic activity, bone destruction, reduced strength, osteoblastic activity, abnormal bone formation, poor structural integrity, mixed lesions, common in metastatic disease. Result, bone becomes mechanically weak, prone to fracture. So, what is the clinical presentation? Red flag symptoms. Patients may present with persistent or unexplained pain, night pain not relieved by rest, pain at rest, unexplained weight loss, fatigue. Fracture presentation. In pathological fractures, fractures occurs with minimal trauma. Pain may precede fracture, delayed healing. Tumor specific signs, localized swelling, palpable mass, neurological symptoms if spinal involvement. Clinical assessment, critical point. Physiotherapists must prioritize screening over treatment. Also, subjective examination. Ask about history of cancer, unexplained symptoms, pain patterns, specifically night pain. Objective examination may include observation, gentle functional testing, avoid aggressive testing, and high load activities. Imaging referral indicators. Patients should be referred for X-ray, MRI, or CT scan. So, and then differential diagnosis of distinguishing tumor-related pain from mechanical pain is crucial. So, I will tell about the feature and how the mechanical pain would be, and how the tumor-related pain would be. So, if it is onset, the mechanical pain would be activity-related. If it is tumor-related pain, it would be insidious. And the pain pattern. Mechanical pain normally movement dependent. Tumor related pain is constant. So night pain feature. So mechanical pain is, in mechanical pain cases it is rare, but in tumor related pain case it is common. And systemic signs. In mechanical pain it would be absent, and in tumor related pain it would be present. So what is the role of physiotherapy? So is it important? Physiotherapy is not primary management in active tumor cases. So primary role is early detection, referral, safe rehabilitation. Physiotherapy in pathological fractures, acute phase. It is immobilization, pain management, protection of fracture. Post-medical or surgical phase, goals are restore mobility, improve strength, enhance function. What is the interventions? So first one is gentle mobilization, progress gradually to avoid refracture, excessive loading. Next one is strengthening, focus on surrounding musculature, functional stability. Third one is functional training, includes transfers, gait training, and activities of daily livings. So, oncology rehabilitation consideration, exercise prescription must consider bone integrity, fracture risk, and fatigue levels. Contraindications, avoid high impact activities, heavy resistance, torsional stress on affected bone. Safe approach, use low load exercises, controlled movements, gradual progression. And then clinical reasoning example. Consider a patient presenting with a persistent low back pain, night pain, history of prostate cancer. Clinical reasoning, possible metastatic spinal involvement, not mechanical low back pain. Action, urgent referral for imaging. Another case, a patient experienced a femoral fracture after minimal trauma. Clinical reasoning, suspect pathological fracture, investigate underlying cause. So prognostic consideration, outcomes depend on type of tumor, stage of disease, fracture severity, overall health. Physiotherapy aims to improve function, independence, quality of life. So what is the key take-home points? Tumors and pathological fractures are red flag conditions. Night pain and unexplained symptoms are critical indicators. Physiotherapists must prioritize screening and referral. Rehabilitation should be safe, gradual, and individualized. So, tumor related conditions remind us that not all musculoskeletal pain is mechanical. So, as physiotherapists, our ability to recognize serious pathology and act appropriately is essential for patient safety and effective care. Thank you for joining this advanced discussion. See you in next video.